Hi everyone, my name is Kelly Ieong and I'm a resident from Stony Brook Hospital. I first would like to thank the Society for giving me the opportunity to present my research. I will be talking about the incidence of reintervention and reoperation following Heller myotomy. I have no relevant disclosures. Achalasia is characterized by the failure of the lower esophageal sphincter to relax. Heller myotomy is the first-line therapy for the treatment of achalasia in patients who have failed other modalities. However, long-term outcomes of Heller myotomy are unclear. The objective of this study is to assess the incidence of reinterventions, either endoscopically or through minimally invasive or resectional procedures in patients who underwent Heller myotomy in the state of New York. Data was extracted from SPARCS, an all-payer administrative longitudinal database that provides patient-level information for each inpatient and outpatient visit, and these include all inpatient and ambulatory surgeries. We identified 1,817 adult patients who underwent Heller myotomy from 2000 to 2008, based on ICD and CPT codes. Through the use of unique identifiers, patients requiring reintervention were tracked up to 2016 for at least 8 years follow-up. Primary outcome was incidence of subsequent procedures following Heller myotomy. Secondary outcomes were time to reintervention and risk factors for reintervention. In this table, we show the summary of the Heller myotomy patients that required subsequent procedures. Out of the 1,817 patients who underwent Heller myotomy, 320 required subsequent intervention. Of the 320 patients, 238 underwent endoscopic reintervention, 54 underwent minimally invasive procedures, and 33 underwent resectional procedures as their initial revisional intervention. 194 patients were solely managed endoscopically, and 54 patients required resectional procedures. This figure shows the incidence of different reinterventions among Heller myotomy patients stratified by reintervention type. In red, we show any type of reintervention. In orange, endoscopic procedures. In blue, minimally invasive procedures, and in purple, resectional procedures. At 10 years, the incidence of reintervention is 23.5% for any type of reintervention, 19.2% for endoscopic reinterventions, 5.5% for minimally invasive procedures, and 3.9% for resectional procedures. Over a mean follow-up of 7 years, the mean time to subsequent procedure was 4.3 years. Risk factors associated with having any type of subsequent procedures after adjusting for confounding factors is shown here. Comorbidities such as renal failure and depression, and complications such as abscess and enteritis were more likely to have a subsequent procedure. In conclusion, the majority of Heller myotomy reinterventions were managed solely by endoscopic procedures. 76.5% of patients required no reintervention after Heller myotomy after 10 years. Heller myotomy remains an excellent procedure to prevent surgical reintervention for achalasia, and it is imperative to set patients' expectations when planning for Heller myotomy and to maintain long-term surveillance postoperatively. Thank you for your time. I'd be happy to answer any questions through the platform or email me directly at the above email address.